And the next presenter is Mr. Elliot Sloane. Elliot, the floor is yours.
Thank you, Amir, and thank you, Rosanna and Pedro, for the excellent presentations. I'm going to talk about the future of virtual health and virtual hospitals in a broader sense, and I think it's really exciting to see the work that's being done throughout Latin America and the Caribbean. It sets the stage for some of the ideas that I'm going to share with you, and perhaps the challenge of what low and middle income countries can achieve in the next generation or applications of these. Next slide, please. I think there's an opportunity for LMICs to leapfrog US and European healthcare activities. And I want to paint a roadmap of that and describe some of the benefits that save cost, increase equity and access, and ultimately improve the quality of care around the globe. Just as we saw cell phones leapfrog wired environments, I think that the opportunity for LMICs in the coming decade is perhaps build less physical large hospitals and have a combination of virtual and bricks and mortar. Next slide. I'll talk a bit about the global journey to virtual hospitals, and then I'll talk about what I see as some of the key success factors, and some have been mentioned already today. Next slide. There's several kinds of hospitals, virtual hospitals. One kind of hospital is almost literally a hospital without beds. It's not almost literally, it is a hospital without beds. A facility that reaches out to all the population wherever they are and whatever time zone they are, and provides medical care. Next slide. This is a concept that was started in 2016 with Mercy Hospital, providing information. And by the way, anyone who would like to have links to this information, I'll be glad to provide them. Mercy Hospital, the next slide, you'll see they actually built a building, a beautiful building, that is all virtual telehealth, telemedicine support. There's no bed. They are providing health to their clinics, to their patients, to the rehabilitation facilities, to the home care, in whatever means, at whatever time of day or night is needed. Next slide. One can easily imagine an environment where you have a government or Ministry of Health where you have virtualized at least some of the care for chronic diseases and for emergent issues. And we'll, by the end, be talking about what's happened in coronavirus. A type 2 virtual hospital, I've said, is one that connects the prestigious physicians in a hub and spoke arrangement. So the pediatric care center of excellence, the cancer center of excellence, can collaborate with regional and sometimes mobile facilities to provide care. We heard examples last month of work that's being done in Africa to do this kind of extended care. Next slide. An example of this is Kaiser Permanente, which has been a leader in this field, providing virtual care, and they talk about more than half of their interactions today are directly through some kind of virtual communication app or site or clinic with telehealth, telemedicine capabilities that allows them to reach more patients. And this past year during the coronavirus and following the coronavirus second wave, they introduced actually a care package that is based on virtual first care. Next slide. There are also the ability to have kiosks either in a building, in a small center like a postal facility, but also in a mobile a vehicle to provide local care and testing. Next slide. A type 3 virtual hospital we're seeing emerge in the US and actually internationally because of coronavirus, hospital and home capabilities. Acute care in home. Now, I have to say 20 years ago, I thought this was pretty crazy. But today, with the kinds of relatively low cost medical devices, sensors, wearable sensors, apps, we do have a possibility, and it is emerging, that we're creating moments of care, days, weeks, sometimes even months of care outside of the hospital with intervention by nurses and physicians to ensure there's a safety net and proper care for the patient. Next slide. One of the leaders in this is the Mount Sinai group in New York City. And fortunately, because of the catastrophic problems they had with coronavirus in the first months here in the US, March, April, May, they were able to accelerate the use of their hospital and home services to provide care at the home for pre and post coronavirus patients. Next slide. The U.S. government has been so impressed with this progress in many hospitals in the U.S. They created a federally government-funded hospital at home program, to which I think there are now 50 different hospitals and health groups that are providing this kind of innovative care for coronavirus patients. Next slide. We're not alone in doing this, but we have so many partners, big and small, who are using the concept of hub and spoke, like Intermountain Health, Mayo Clinic, Mount Sinai, connecting to smaller facilities to provide care out to their patients as well. Next slide. We're not alone in this. The UK, in January of this year, launched their own virtual hospital virtual ward program. So they have two programs, actually. One is a pulse oximetry to the patient, delivery of a pulse oximeter, so the patient can manage their oxygenation levels, communicate with nurse care, so they don't necessarily have to come to the hospital. And also this virtual ward to keep the patient at home or send the patient home quickly post-COVID care with oxygen support and oximeters and monitors to keep them safe and accelerate their wellness. And also, of course, open up beds in the hospital for more acutely ill patients. Next slide. Mount Sinai Hospital is one of those leaders and is now adding on AI. So as Pedro discussed, AI has been used for diagnosis. Now they're adding AI to help support treatment and support best practices for these patients in these very novel settings. It makes a lot of sense. If you have 20, 40, 50, 100 different patients in different settings with different degrees of acuity, it's helpful to have a smart system providing vigilance and pulling in the caretakers and care levels that are needed to support the patient. Next slide. Of course, the question we will all face is exactly, what is the goal? What's the justification for doing this? With the coronavirus, the justification is, first of all, slow down the admission of patients. If they don't need to come to the hospital, if they are safe and stable and will recover on their own, bring them to the hospital may actually make matters worse, both for the patient and overloading the hospital. And then once the patient is stable after coronavirus treatment, whatever treatments are used in the hospital, keeping them in the hospital, especially with the experience of long COVID, where people can have symptoms that last months, they have to be sent home. I actually was in a restaurant last night and someone sitting next to me had a portable oxygen concentrator. He said he was in the hospital for 28 days. He's been now home with portable oxygen for 3.5 months. He's grateful to be alive. Those kinds of innovations can be supported with this kind of remote monitoring. Next slide. Just some key success factors. Next slide, we have the easiest form of care is mHealth, mobile health, things with apps, things with simple sensors. We can get pulse oximeter and heart monitoring apps and sensors for in the area of $50 to $60 US. And those can be provided on a short-term or long-term basis to patients. Medium acuity patients, stable chronic disease patients can be supported with telehealth, just checking in with them periodically to make sure that their oxygen saturation, blood sugars, respiration are all being controlled adequately. And then in terms of high acuity hospital at home, acute care at home, telemedicine, where the physician team is engaged with the patient, perhaps even 24/7. Next slide. In all of this, I'm not saying that every part of these examples will apply to every nation. Each nation has to adapt and adopt the tools and techniques that fit their budget and their state of technology support. Artificial intelligence, machine learning, I mentioned before. Rosanna mentioned standardized unified patient exchange and standards. We still don't have that in the US. We still don't have that globally. We have not seen an ecosystem evolve yet of interoperable information systems, and yet that hasn't prevented the development of these systems, and I think that they will continue to grow organically. Next slide. Obviously, the compelling opportunity for a nation is to support as many people as possible in a patient-centric way, using big data and AI to support and justify and improve the quality of care. Nurse and physician productivity is a massive issue. Our nurses and physicians are overloaded and will continue to be overloaded in this 21st century. And then reducing duplicate services, erroneous services, all part of how a smart health system should operate. Next slide. The vision is to have consistent high quality care for everybody. On the bell curve of physicians and hospitals, in the middle, you have this median. We need to push the whole curve forward to have people have more higher quality care more consistently. Next slide. So I've talked about the virtual hospitals, the concepts, the opportunities, the key success factors. Let me just give you a couple other thoughts as I close. Next slide. We're working with a team in Queensland, in Australia, very sparse area. Ranchers live on 5,000-acre farms by themselves or with their family. Providing care for these folks, coronavirus care, long-term care, chronic care, it really has motivated them, even with their low budget and vast geographic area, to begin to innovate and use virtual hospital approaches. And I think that every country and nation has an opportunity to apply pieces of this in the right place, whether it's urban or rural. Next slide. So our job, I think, as CED is to work together as a community, share ideas, share knowledge, share pointers to best practices, and to help each of you, each of us, create a better healthcare world, whether it's using bricks and mortar, clicks and mortar, or virtual healthcare. Thank you very much. I appreciate having joined you today. I look forward to the rest of the presentations.
Thank you, Elliot, very much for all these such a kind and such a great results and experience which you shared with us. Thank you very much. Let's